Hi, thank you for your time today. My name is Rachel Chariton. I'm an occupational therapist, hand therapist in Ames, Iowa. My presenting case is on a 38-year-old female, right-hand dominant, right-affected artist and high school teacher. She suffered a P1 fracture to the small finger with percutaneous pinning on 6/15. This was following just a fall when she was out running. Her first appointment with me was the 21st. Her measurements are shown there, and then she got her pin removed on the 14th of July. There's a little bit of complication with this because her surgeon was in a different city. She came to me, which was her home city, because she was on vacation when this all happened. So surgeon was not the same doctor that was following her. So anyways, there was pin removal on the 14th of July. So her range of motions are below following that pin removal, so we did have significant limitation with MP flexion and or MP extension and a lot of other range of motion limitations. The following video was after a couple weeks of therapy and kind of see where her motion was.
Go ahead and make a fist for me.
Might be able to go up like, the normal way, but those days where it's more sore and stuff, you're gonna have to
Okay, and straighten on up.
go one at a time. That's fine. There's nothing wrong with that. And that's why they have trainings. That's why
Make a fist for me.
it's not a loss. It's not a step back.
And straighten back up.
Yeah. Good.
One more fist.
So just keep moving, keep these exercises going. Just work on that.
Go ahead and make a fist for me.
Might be able to
So I've tried multiple different techniques, and at this point I'm pretty concerned that there is no real good active glide of FDS or FDP in that small finger. So tried multiple things. I did do an MCP flexion blocking orthosis on the 19th of August, and we used that for about 3.5 weeks. During this time, my wheels were turning, trying to figure out what our steps needed to be. And I was very aware of CMMS just from other courses I had taken, at least just aware of it, not really to the point where I was confident in implementing it. I did put out a ASHT little blurb seeing if other people could potentially help me brainstorm a little bit of this, and I also had come across Robyn Midgley's training. So this was quite a journey for me. So I did reach out. With ASHT, I did actually get some info back from Judy herself, surprisingly, which was awesome. And then I did feel like I needed some coaching along the lines. I didn't feel comfortable just doing this by myself. So hence got to Robyn Midgley. So anyways, we did do one little video chat with Robyn. She was very willing to do that, and so we initially started with the 2 cuff casts on the 13th of September. The following video will show you just what her range of motion looked like prior to us casting her. As you can see in this video, she does the hook fist and also the composite fist. She's doing an intrinsic plus kind of movement pattern, especially with that little finger. She also has a hard time just having a fluid motion. As you can see, and then these are the casts that I did apply to her. This is the PIP cuff cast, one of two. I asked her to extend her hand as well as flex her hand. There's a little dot for a target for her finger to reach as she flexes. She wore this cast about 60% of the day and completed exercises frequently, basically every hour. Shows the DIP flexion cuff cast. Again, extending the fingers and flexing the fingers. That there's again a little dot to serve as a target for that tip to reach. And this one she wore about 40% of the day, and again completing the exercises about every hour, several reps. This is the PI. And then once we were done with those cuff casts, this was what she was able to do, and also part of the reason I decided to go into a full cast. So that was just a static picture of what her composite fist looked like. So the full cast implementation was the hook fist cast. We started that on the 3rd. So I did that because she did have some compensatory techniques at that wrist, and I was also probably getting a little impatient because at this point we have been doing things for quite a while, and I just wanted to get the best possible outcome for her. And she did gain some range of motion with those casts, but I did think that she might even get more if she went into the full-on cast, and this certainly did take some level of convincing, and part of it could also be my lack of confidence with the whole thing. I probably did not portray myself as saying this was going to be the best option for her, because this is all very new to me, and definitely a trial for me as well, which is also probably why it took us this long to get to this point in the first place, as well as all of my training with Robyn Midge's class, and trying just to get all this underway, along with all the other life things that we all are trying to juggle at the same time. So anyways, we put her into a full cast. I do kind of show a little bit of the blocking, what her difference is between a composite fist and also what just the blocking in general looked like. So we did this for about 3 weeks. I saw her 3 days after her first application just to check in and make sure things were functioning the way we wanted them to function and there were no issues with the cast. And then another week later to check in, and then about 1.5 weeks later with the idea to remove that cast. So here is what she looked like in the cast. The patient was asked to flex and extend her fingers in that hook fist. There was also a little dot placed on the cast. It's not shown currently, but it was placed on that cast to give her a little target for the pad of her small finger to try to reach. She was asked to do these about every hour in several repetitions throughout the day to get as much as she could. So then upon the removal of the cast 3 weeks later, her range of motion looks like this. Of course, I internally freaked out a little bit with that MP flexion there, or lack thereof, but I also knew in the back of my head that both Judy and Robyn said not to worry so much about that that joint, that it generally comes back fast. But of course, that initial scare still got me. But her PIP and DIP looked beautiful, and I was so happy with that outcome. I was just impressed that we got that far, and I did also show that she gained about 20 degrees of that MP flexion just in that particular session.
And back up. Make a fist. And back up.
And you can also see that she developed a little bit of a flexion contracture, which also made me a little nervous because she was to see the doctor again. One week, and this was a first for the doctor as well. In when I approached him with this idea. So I certainly wanted everything to look good for her return upon the doctor. And again, remember that this doctor was not her initial surgeon. It was just a follow-up with one that was in her hometown. So I wanted to do everything that I could in that 1 week time frame to get the best range of motion possible. So I did implement a static progressive MP flexion splint because I wanted to make sure that that thing was not gonna backfire on me. And then I also did implement a nighttime gutter splint for that PIP finger extension splint due to that contracture, and hope that also would not backfire on me. So all in all, after this was all said and done, it was probably another couple weeks. I only saw her about 4 times after we took that cast off, last being this past Friday. And therapy's not completely out of the picture. She sees the doctor again on the 30th. But I think, anyways, this is her range of motion.
Okay, go ahead and make your fist.
On Friday.
Try not to cheat with it.
Okay, should I go again?
Yep. There you go.
Now, she was very good at cheating with use of that ring finger when she went down into her composite fist. So there were a few times that I had to double check and make sure that that small finger wasn't just passively being moved by that ring finger to get the most accurate motion. And this is one thing I wasn't sure when she did come out of that the cast, when we did get her MP flexion down better. I wasn't sure if when I got those measurements, she initially had about 70 degrees at that PI, or at the DIP, and it looked good when the cast first came off, but then as things went on, her MP flexion got better. She lost a whole bunch there. It was, I think her ending was 45 degrees at that joint. And so I wasn't sure if maybe there was just a false reading at some point to get that 70, or if it was a true reading and then we did lose a little bit of that flexion when we went into that extension, the gutter splint at night, if that did lose some of that tendon gliding. So I'm not really sure what might have happened there, but this was her end result, which is way better than what we started with.
Okay, go ahead and make your
So kind of at a glance, those are just the measurements throughout from June, end of June, until the middle of November. So multiple changes, a lot of learning on my part. Her grip strength, she felt, well, it measured pretty accurately to her non-dominant side, and her leg to distal palmar crease was about 1.5 centimeters, which I would have hoped for a little bit more, but I certainly was grateful that she gained a lot more than what she initially had. So she felt she was about 85% of her previous function. There was still some fatigue with some activities such as writing and drawing, but overall she felt she was able to do what she wanted to do. I did kind of get the vibe that she was going back and forth as to whether or not to continue with therapy or what, but at this point her finger and her hand exercises dwindled a lot throughout the day. She certainly was not making it a priority anymore, so I know that mentally she was just exhausted from working on her hand, and other life events were certainly more of her priority at the time because her hand was functioning at a much better rate. So I think just mentally she was exhausted, and I did tell her that we could potentially continue to try to get even more, but it would have to be a priority and something that she would continue working really hard on. So at this point, I don't anticipate seeing her anymore unless she does end up going back to the doctor and he has other views, or she thinks about it and wants to see me still for some more. I'm certainly happy to try to see if we can gain any more, because just from last week to this week, she did gain about 10 degrees in her PIP joint. So she's still making some gains in some way, shape, or form. But at this point, it had been a very long time, so she was certainly ready to be able to just go on with life. So that is my case. It was certainly a big learning curve. And I still have so much more to learn about CMMS, but I do feel like it is certainly a big benefit and tool to have in our toolbox as something that we can use for people that aren't otherwise performing like we would like them to, or other techniques are not working. So I am very grateful for all the things that I learned in Robyn Midgley's class, because that's what I needed, was something to show me how to do things, to help some of that confidence. And it is always good to have people to bounce things off of when you are learning a new technique. So that is my case. Thank you so much for listening.